Yes, students, this topic is fibrous dysplasia, which is one of the fibro-osseous lesions occurring in body. And here, the normal bone is replaced by fibrous connective tissue trauma. First lesion is fibrous dysplasia, the term coined by Louis Lichtenstein in 1938, and it is described by von Rickel-Hansen in 1891. Here is a picture of a child, which is the child has fibrous dysplasia, and her skull image is showing here. The synonyms of fibrous dysplasia include fibrocystic disease, osteitis fibros localista, and the focal osteitis fibrosa. Fibro-osteodystrophy, also the name for fibrous dysplasia. Fibrous dysplasia is a developmental tumor-like condition which is characterized by replacement of the normal bone by proliferation of cellular fibrous connective tissue with irregular bony trabeculae. Fibrous dysplasia is a skeletal developmental anomaly of the bone-forming mesenchyme and which manifests as a defect in osteoblast, its differentiation and maturation. Then the bone in the body can be, any bone in the body can be affected. It is a non-hereditary disorder of unknown cause. The resultant fibrous osseous bone is more elastic and structurally weaker than the original one. Hence, the hallmark of the disease is a solitary focal or generalized multifocal inability of bone forming tissue to produce mature lamellar bone. They are arrested at the level of woven bone. That is, they consist of immature bone rather than mature bone. The genetics behind fibrous dysplasia is the active mutation of the NAS gene and which causes fibrodysplasia. And during early embryonic development, mutation of stem cell occurs and which result in defect in osteoblast, melanocytes, and endocrine cells. If the mutation occurs at the later stage of embryonic development, only the osteoblast will be affected. If the mutation occurs during postnatal life, then the osteoblast in single bone affected. Hence, there are types of fibrous dysplasia include monostotic fibrous dysplasia, polyostotic fibrous dysplasia. In polyostotic form, here, Jaffe-Lichtenstein syndrome, McCune-Albright syndrome, Messerbrand syndrome also there. Mutation of NAS gene overproduction of mutation of NAS gene result in overproduction of cyclic AMP. The effect of increased level of cyclic AMP is hyperfunction of endocrine organs and increased proliferation of melanocytes, effect on differentiation of osteoblasts, and thus leading to fibrous dysplasia. This we already told. The mutation in the early embryonic life, the stem cell is affected and the multiple bone lesions and cutaneous pigmentation and endocrine disturbances occurs. If the mutation in the very early stage of embryonic life resulted in a lesion known as McCune-Albright syndrome, in which multiple bone is affected, cutaneous pigmentation will be there, and the endocrine disturbance is also there. If the mutation occurs during later stage, only the bone will be affected. That is your multiple bone lesions or polyostotic fibrous dysplasia. If the mutation occurs during the postnatal life, only single bone is affected. Monostotic type mutation takes place after birth, while the polyostotic types takes place during the late stage of development of embryo. The monostotic fibrous dysplasia, disease is limited to single bone. Second and third decade of life is affecting. Male and females are having the equal frequency of disease occurrence, and involved sites include craniofacial bones, ribs, femur, and tibia. The maxilla is more commonly affected than mandible and has the predilection for the posterior region. Mandible lesions are truly monostotic. Maxillary lesions often extend to involve adjacent bones like zygoma, sphenoid, ethmoid, frontal bone, and temporal bone, hence which is known as craniofacial fibrous dysplasia, which is a painless unilateral swelling. Growth is generally slow and adjacent tooth may be displaced. Here is a picture of a woman showing fibrous dysplasia. One side of the face is affected. Here is an expansile mass of the left maxilla. Here is also an expansile mass. The radiographic features of fibrous dysplasia plays an important role in diagnosis. The classic radiographic findings of fibrous dysplasia is fine ground glass opacification with poorly defined margins. Some lesions may appear radiolucent or mixed radiolucent and radio-opaque. Mandibular lesions often exhibit buccolingual expansion and bulging of the inferior border. There may be superior displacement of the inferior canal. Periapical radiograph of the adjacent dentition may demonstrate narrowing of periodontal ligament space as well as ill-defined lamina dura. Here is a picture showing the radiolucency of that lesion. There are three basic patterns may be seen. In one type, the lesion is generally small unilocular radiolucency or somewhat larger multilocular radiolucency. Both will be having a well-circumscribed border containing network of trabeculae. In second type, there is increase in amount of trabeculation and leads to more mixture of appearance, that is mixture of radiolucency as well as radio opacity, and giving a mottled appearance. Third type, it is a ground glass or orange peel appearance. Here there is a mixture of both. Histologically, we can diagnose fibrous dysplasia due to the proliferation of fibroblasts in compact stroma and forming interlacing collagen fibers. There will be a characteristic appearance of the trabeculae, that is C or S-shaped trabeculae, and jigsaw puzzle can also be seen, and Chinese letter pattern appearance also seen. The trabeculae consist of immature non-lamellar bone without osteoid rims or osteoblasts. Trabeculae mainly of woven type, that is, it is immature bone and hence it is not having a proper osteoid or rimming of osteoblast. This is the picture showing the characteristic Chinese letter pattern appearance of the fibrous dysplasia. Next lesion is polyostotic fibrous dysplasia. Here, involvement of two or more bones occurs. Female predilection with 3:1, and bone size affecting are femur, skull, tibia, humerus, ribs, fibula, radius, ulna, mandible, and vertebrae. If polyostotic fibrous dysplasia along with cafe-olid pigmentation is seen, we can diagnose Jaffe-Lichtenstein syndrome. Polyostotic fibrous dysplasia, cafe-olid pigmentation, as well as multiple endocrinopathy will go for McCune-Albright syndrome. Mesebrad syndrome is a polyostotic fibrous dysplasia in which intramuscular soft tissue myxoma along with polyostotic fibrous dysplasia. Here is a picture showing the cafe-olid pigmentation seen in McCune-Albright syndrome. We can see that it is having jagged border, and it is seen only on the side of the lesion, that is unilateral occurrence. Cutaneous pigmentation in polyostotic fibrous dysplasia is ipsilateral, that is to the side of the bony lesions, a feature that differentiates the duration of the disease from neurofibromatosis. Neurofibromatosis is another lesion in which cafe-olid pigmentation can be seen. microfibromatosis type, there is irregular arrangement of the skin pigmentation, that is, you can see everywhere in the body. In case of fibrous dysplasia, it is seen only at the side of the lesion. The location and shape of spot usually can help to distinguish between these two lesions. The spots in McCune-Albright syndrome have jagged borders, whereas in neurofibromatosis, it is smooth and regular. Here is a picture showing one side of the body showing cafe olive pigmentation, that is coffee brown pigmentation. Frequently identified deformities include coxa vara. It is the deformity of the hip whereby the angle between the head and shaft of the femur is reduced less than 120 degrees. Next, bowing of the tibia, then the Harrison groove. Harrison groove is an horizontal depression along the lower border of the thorax corresponding to the costal insertion of the diaphragm. These are the pictures showing coxa vara, bowing of tibia, and the Harrison groove. Next lesion is craniofacial fibrous dysplasia. This is nothing but the fibrous dysplasia which is occurring at the craniofacial bones. Occurs in 10 to 25% is the monostotic form and 50% with polyostotic form. It is an isolated craniofacial form, and in the isolated variety, it is typically present at the age of 10 years and progress throughout the adolescence. Here is a picture showing fibrous dysplasia which is occurring at the craniofacial region. Diagnosis of fibrous dysplasia mainly based on CT scan, MRI, conventional radiograph, and nuclear sonography, biopsy. Then the mutational analysis of NAS1 gene, lab diagnosis of endocrine disturbances. These are the radiographic features. In early stage of the lesion, it appears as ground glass appearance or motile mixed radiolucency or radiopaque pattern. Then the critical feature to diagnosis is it does not have a discrete margin. Rather, they blend into the surrounding tissues. These are the pictures showing 3 stages of the radiographic appearance. In early stage, they appear as classic ground glass appearance, and there will be increased trabeculations in the second picture, and the third picture showing mixed radiolucency and radioopacity having characteristic orange peel appearance. This is the CT scan image showing lesion with radioopacities. This is the fibrous dysplasia in MRI scan. Next is the NAS gene investigation by direct sequencing or polymerase chain reaction. The differential diagnosis of fibrous dysplasia mainly consists of hyperparathyroidism, Paget's disease, pigment-ossifying fibroma, and osteomyelitis. In hyperparathyroidism, they produce a similar pattern, but these diseases are polyostotic, bilateral, and unlike fibrous dysplasia, do not cause bone expansion. Hyperparathyroidism is a disease affecting bilateral and do not cause bone expansion. But in case of fibrous dysplasia, it is unilateral and causes expansion. Paget disease is a similar disease, but it occurs in older age, and it involves mandible. The whole mandible is involved, unlike unilateral tendency of the fibrous dysplasia. Next is the cemento-ossifying fibroma. Here, the trabeculae will be lined by osteoclast, hence we can differentiate with the histopathological slides. Next is the osteomyelitis. May result in enlargement of the jaw, but the additional bone is generated by the periosteum. Therefore, the new bone is laid down on the surface of the outer cortex. Fibrous dysplasia, in contrast, expands the internal aspect of the bone, displacing the thinning of the outer cortex so that the remaining cortex maintain its position. The identification of sequestra aid in identification of osteomyelitis. Sequestra is nothing but newly formed bone can be seen in osteomyelitis. The management of osteofibrous dysplasia include there is no active treatment is required, but some trimming is necessary. Bisphonate and systemic steroids can be given, and radiation therapy is contraindicated because there is a risk of post-irradiation osteosarcoma.